So we will start.
Yes,
Uh,
please. Yes, please.
hmm. Good evening, all the faculties and delegates for the search, and I welcome for the Searchlight 25 webinar series. And today's topic is on Adolescent AUB, which is initiated by Cancer Prevention and Relief Society in association with Bhimavaram, Kanpur, Manipur, Nagarkoil, Namakkal, Nanded, and Nalbari Obs and Gynae Society. So first of all, it's my honor to welcome our convener, Dr. Sujesi Sangita. Madam is a founder secretary of Bhimavaram Ops and Gynae Society and got so many awards and currently practicing as a consultant of Ops and Laparoscopy at Seshadri Hospital. And it's my honor to welcome Dr. Asha Jain, who is the medical director of CPRS. And there is no need to introduce the ma'am, but it's my honor that I am going to introduce. And madam is the director of SMSA Hospital Raipur and medical director CPRS. And madam is the elected member of CG Medical Council and Zonal Chair Food Drug and MSc Committee West Zone. Madam is a chairperson, chairman Mission Pink Health IMA Raipur and executive member of ISCCP CGSR and CGSFM. And Madam is running Foxy recognized center, training center for the ultrasound and colposcopy training, and have so many academic associated with so many academic societies. So, ma'am, welcome to you, and please make it to the newer height, reach it to the newer height.
Thank you, Mehul. Would you play the prayer next before I do the official welcome? Before we start anything, we start with prayers to the divine. So I invite everyone to join in for the prayers. Thank you. Now I would like to welcome all the members from Bhimavaram, Kanpur, Manipal, Nagarkoil, Namakkal, Nanded, and Nalbari Obstetric Gynec Societies. I want to welcome our chief guest, Dr. Ambuja Churanur Madam, guests of honor, Dr. Haresh Doshi Sir, Dr. Rosa Oliai. I would also like to welcome my convener, Dr. Sujeshri, our speakers, Dr. Jyoti Bhaskar and Dr. Jyotsna Suri, Chairpersons Dr. Reshma Nigam, Dr. Rajesh Bhaktha and Dr. Sundar Narayanan. Also, Dr. M. Chandra Ponnusamy, Dr. Anil Sakhare and Dr. Gopal Kalita. I welcome all of you to this program. I welcome my expert, Dr. Geeta Mekot ma'am, and our panelists, Dr. Rashmi Ajith, Dr. Pooja Toshniwal, Dr. Dipjyoti Das, Dr. Nalini Katta, and Dr. Nirupama Palakode. Namaskar. I hope today's Searchlight on Adolescent AUB will actually help us all to focus our attention on something that everybody deals with day in and day out. I would like to welcome all of you, and we start the program, the inaugural ceremony. I would like to invite my chief guest, Dr. Ambuja ma'am. May I have a CV, please? So Ambuja ma'am has been kind enough to agree to be our chief guest. I always knew her as somebody from Indian Menopause Society. But I was told that Madam is passionate about adolescent health and she has done extensive work for adolescents in Hyderabad. So I'm really honored to have you here, ma'am. Ma'am was the IMS representative to SAFOMS, President Indian Menopause Society 21-22, Research Committee Chairperson SAFOMS 21 to 23. She's a retired professor and HOD, Institute of Gynae, Osmania Medical College, Hyderabad, visiting Professor Savita Medical College, Chennai from 2019 onwards, All India VP, Family Planning Association of India, Faculty and Resource Person DNB from 2001 till date, and treasurer of SOMI, peer reviewer of Jogi, JMH, MRIMS, consultant editor, JK Science, Journal of Medical Education and Research. She is very well decorated, a really humble, very loving person. Ma'am, I'm really honored to have you here and would love to hear your blessings and in future to agree to be a speaker in my program.
Thank you very much for your kind introduction. Today I am extremely happy, and thanks to Asha for inviting me as chief guest for this prestigious program, which is very, very innovative, I tell you, Asha. Keeping in mind of so many students, postgraduates, and general practitioners, what are all the problems you are bringing day-to-day activities into that, because I'm seeing from the beginning the Searchlite programs, what are all the programs you have brought in. And second thanks is for giving the opportunity to meet all my friends. The first of all, it is Harish Doshi, whom I was colleague, and we both together were MD examiners in Aurangabad. Is it not so, Dr. Doshi? Where as examiners we conducted CMEs. That time no slides also for us, and we were so enthusiastic, and without any lights we started teaching the students, both of us. That was a nice experience, Dr. Doshi. And Rosa, really, it is a great time we had together in family planning. I know her, how such a nice book she has released on adolescent health and education. After I met you, I read the book from front page to last page. Oh, really, it was a wonderful book, Rosa. And Jyoti, I cannot tell anything about you. We are so great friends and together did so many programs. And this is an opportunity to meet all the members of Bhimavaram, Kanpur, Manipal, Nagarkoil, Namakkal, Nanded, and all the other obstetrics and gynec societies. I say Corona, how much it damaged people, but for the medical fraternity, I feel a lot of webinars. We came into having the webinars only because of the when Corona. Before that, we never had it. It was a rare occasion we had, and meeting so many people would not have happened if it is not webinar. And second thing, you have selected such a wonderful topic, I'll tell you. This is one of the unmet needs of the society. Adolescent education, whatever you said, we have progressed so much. Day in and out, we are standing on the stage and telling we are doing that, we are doing this. But I feel absolutely this is going into deterioration. Whatever is the thing, morals are not there for children. Not that they are highly educated and highly intelligent, but what is happening to their intelligence also, you don't know. Maybe in some way we are also responsible because of the single child norm and nuclear families and both parents working. Lot of money, no time for the parents to take care of the children, and where they are going, we don't know. What they are doing also, we don't know. And who is there to guide? It's only the peer and our own telephone and internet. That is the one, always it is guiding them. And And sexual promiscuity, definitely it has increased, not to the extent of the Western world, but still it is there. And that is the one causing all the many a times. And easy availability of the OC pills wherever you are. We ourselves are encouraging, because in Hyderabad we did a adolescent program to the school children and to the I mean degree first year up to first year students. We went and told, I mean, more than 1 lakh children we covered. In that, one of the program is to use the OC pills whenever it is necessary. About the emergency contraceptive pills, I don't know how much correct or not. Today, they are all ending with so many problems of having the DUB, and knowingly, unknowingly, they are not revealing them. So, somewhere we have to meet ends to know how to correct the things. Really, it is a I mean, very good topic what you have selected, Asha. And I wish all the best for you for your contesting for the elections for the food and drug and medical and surgical equipment what you have selected. All the best for you. And I wish all the best to all the societies who are participating very actively. And my intention is all of you, please do lot of adolescent programs. The first, anything that starts from the house first, try to correct your children and then go to the society. That's what is my advice. And I too did like that. Until my children are grown up, I never started any private practice. My whole time after my hospital, because I worked in the government hospital only. And of course, on the duty days, it was inevitable, but otherwise, I used to spend my time with the children. So they need that type of affection. So that's the main thing, what is necessary before going into the public and teaching them. We have to correct ourselves and then take care of our children first and then go to the public. It's a good thing that to meet you all. It's a great opportunity for me. And again, thank you, Asha, for inviting me as chief guest for this program. Thank you all. Namaste.
Thank you, ma'am. Thank you so much for those kind words. It's a pleasure having you here. And now I would like to introduce Haresh Doshi, sir.
It's okay. It's okay.
Sir, थोड़ा सा बोलने दीजिए. थोड़ा सा.
दो line.
Sir is professor and HOD obstetric gynae, GCS Medical College, Ahmedabad. He was president of Ahmedabad Society and SOGO. He was VP Foxy 2019, ICOG Governing Council member still, and he's going for ICOG Vice Person elect this year. So welcome, sir. Welcome to this forum, and I'm really happy that you agreed to grace the occasion.
Thank you, madam, for making my introduction short. First of all, I must congratulate you. Thank you first, and then congratulate 25th episode of Searchlight, a powerful Searchlight. Every time I used to see you're in the right WhatsApp group, the topics, the speakers, and you are doing a wonderful work. And most importantly, nowadays, because of webinar, we are able to involve the smaller societies of our Foxy. And that's why you have Bhimavaram, Kanpur, Manipal, Nagarkoil, Nanded, Namakkal, and Nalbari Society. Right? So 8 societies, I mean 7 societies together. I also thank our chief guest, Ambuja madam. She has said everything about adolescent health. And she also mentioned that when we were a co-examiner and a colleague more than 30 years back, it was not a PowerPoint or laptop. It was a slide projector. And then she had missed her slides. Without slides, she took a wonderful lecture. A DIC, difficult topic at that time. I just remember that there's a great faculty, I must say, Dr. Ambuja madam. Roja madam, I've been to Gwalior. She is my co-guest of honor. Then our program convener, Sujashri Sangiti, and all the speakers, Madam Jyoti Bhaskar and Jyotsna Suri, and all panelists and chairpersons. Uh, right, adolescent health, as you know, Madam has said that unmet need, somewhat right, half touch or neglected. We are busy in our during medical college and after also in practice with other OBGY, which are more important practice, and that's why adolescent health remains somewhat untouched, less discussed. Our government of India has also started more than 10 years back Rashtriya Kishore Suraksha Karyakram, that is a holistic approach for adolescent health. So I understand this is a very important topic. And this Sunday also I'm speaking at Coimbatore conference for adolescent endometriosis. So this is today adolescent AUB. I congratulate Madam again and thank you for inviting me. And also, right, like your right committee chairperson said, I request all the right delegates and faculties who have joined for giving me the vote during September first week for vice chairperson ICOG. I will not stay between the wonderful academic program. Thank you, madam.
Thank you so much, Harish sir. All the best. And
thank you.
Thank you for being here. So now I would like to welcome and introduce my dear friend, Dr. Rosa Oliai. She is the director of Oliai Hospital and Research Center. She is currently the president of Gwalior Society, chairperson SBC Madhya Pradesh, member National Screening Committee, Family Planning Association of India, representative board of trustees, Hukuk South Asia, fellow and member board of governing council ICOG 2018 to 21, VP Foxy 2014, chairperson Adolescent Health Committee Foxy in the year 2012, and FIGO representative WHO session at the FIGO World Congress at Rome 2012 during the special session on preconception care. And she's also a WHO consultant, expert panel meet for making global guidelines on adolescent sexual reproductive health. Madam has already, Ambuja ma'am has told about the book she has written. So recent advances in adolescent health. She's awarded the Mehru Hansotia Prize, Dr. D.C. Datta Prize, and she's authored 4 books and co-authored 8 books in obstetrics and gynecology. Welcome, Rosa. Welcome. And I hope you find the program useful.
Of course, Asha. Thank you so much for the very warm introduction. I couldn't stop you because I knew you go on reading your guest always. So, Asha, first of all, I must congratulate you for having these topics which are, not much talked about. We have other high kind of, topics which are there with PCOD and all. But AUB in adolescence is something which less talked about. And I see that you've done the Searchlight over months together, weeks together. So wish you all the best. Your selection of topics, your selection of guests, I was just going through the resume, is fantastic. I would really wish you all the best for your election for the Food and Drugs Committee of Foxy. And I know your caliber. I'm sure you'll do Foxy. We need people in Foxy like you. Coming to our dear guest of the chief guest, my dear friend, Dr. Ambuja. I worked with you in family plan, still with the Family Planning Association of India, and you are being with me in that. I've seen the way you have worked together. Really a good guide, a good mentor to everyone. I really enjoyed those days working and learning. And I know your good work in, the section of adolescent health. We always used to talk about that. That's why we had a common interest. So good to see you. And I'm so happy Asha brought us together on this platform. Dr. Harsh Doshi, we've been together in Foxy as chairpersons, as vice president, and I'm so happy that you're now going as for the election of the ICOG chairperson. I wish you all the best for that. We have good speakers. I just came to be introduced to Dr. Jyoti Bhaskar and Dr. Jyotsna Suri. It's such a lovely platform, Zoom, that, Asha, you brought up good speakers here. We are going to wait to hear more about your topics. Just a little note on anemia and adolescents, because, we talk about anemia and prevention and doing all that, not knowing that the heavy menstrual bleeding that they have, AUB that they have, is a cause of this anemia. We think about deworming, we think about everything else. But the root cause, the hormonal imbalance, which is very, very common, and I'm sure the speakers will highlight about the ESHRE guidelines, which is come with minimal medications, that's it. And a good counseling when the patients come, the little girls come with their mothers. So wish you all the best. Asha, again, thank you for giving this platform. Great. It's not easy to have Zoom meetings. And I know the way she works hard in ringing up everyone personally, making sure we start on time, which is commendable. You started at 5. Fantastic. And I'm sure I don't want to speak more so that you can have more concentration on your speakers. Thank you so much.
Thank you so much. Thank you, Rosa. Thank you, Haresh sir and Ambuja ma'am. With this, we come to the end of our inaugural session. If my guests have the time, they can be there for us. Otherwise, we start the academic session with due blessings from you all. And I would like to introduce the chairpersons of the first session, Dr. Reshma Nigam.
Thank you, ma'am.
Ma'am is the secretary of Kanpur Obstetric Gynec Society. Ma'am, welcome. We have Dr. Rajesh Bhaktha, sir, who's the president of Manipal Society. He has a very special interest in gynec endoscopy and reproductive medicine. Next, please. Very many awards. We also have Dr. S. Sundar Narayanan, who's a gynecologist and fertility specialist, president of Nagarkoil Obstetric Gynec Society. His interest is also endoscopic surgery and ART. Welcome, sir. I welcome you, chairpersons, to this forum. I request one chairperson to please introduce the speaker. Yes, sir. The other to introduce the topic and the third to sum up, please. Over to you.
Yeah. Thanks a lot, madam. Thanks a lot, Asha, madam, especially for inviting me as a chairperson for this wonderful session, madam. We met a lot at I think we have met last at Mumbai, ma'am. And many congratulations for your chairperson as a committee chairperson, madam. And regarding the speaker, it is a great pleasure to introduce Dr. Jyoti Bhaskar. She's the additional director, consultant, obstetrician and gynecologist at Cloud9 Hospital, Delhi and Noida. And she's the chairperson of Adolescent Subcommittee of AOGD from 23 to 25, and the secretary, Delhi chapter of IMS from 23 to 25, and member representative of AICC, RCOG, New Zealand to RCOG. And she's the past president of East Delhi Gynec Forum and co-chairperson of QA committee of AOGD. And she's a member of AOGD subcommittee of Safe Motherhood and Endometriosis 2019 to 21. She's also a member of the AOGD committee of cervical and breast cancer awareness and critical care in obstetrics from the year 2016 to 18. She's also an executive member of NORCHI from 19 to 23, and she's a member of AOGD subcommittee of adolescent health from 2012 to 16. And she was the secretary of Delhi Gynecologist Forum East from 2015 to 17. And her major achievements, she won the President Gold Medal for standing first in Delhi University, the final MBBS, and the APJ Abdul Kalam Appreciation Award by DGF in 2016. And Sigisha, which is the award from IMA East 2016. And she is a teacher, speaker, chairperson, and panelist at various national and international conferences. Welcome you, madam.
Thank you so much, Dr. Sundar. And I'll just share my screen. I'll make this. So, good afternoon. And on my behalf, I'd like to thank Dr. Asha for having me, to make me a part of this wonderful academic feast. I would waste no time and I would just go on to my particular topic. I would just like to say that I have used this particular background of my PPT just to say how important it is for us gynecologists to take care of that little flower on the left, which is an adolescent. And if we do so, only then can they bloom up into a beautiful woman. The sources I have used is from the up-to-date, the abnormal uterine bleeding evaluation and approach, the abnormal uterine bleeding in adolescents, the screening and management of bleeding disorders in adolescents, that's the ACOG committee paper 785 of 2019. I was wondering that why exactly are we having this particular talk or I would say a webinar on AUB. Is it that common? So we need to really understand that it is the commonest disorder in the adolescents. And in a study which was done about 1,000 adolescents, they found that 40% of the all adolescents, they were suffering from AUB. And more importantly, as Dr. Rosa said, that this particular AUB leads on to anemia and leads on to decrease in the quality of their life. And this is something which I tried to find out in various papers if we did have a value to how badly and how severely it affects. I was unfortunately not able to get that. But yes, we all know that if these children are anemic, if these children are suffering from AUB, it affects all the quarters of their life. As postgraduates, we have all learned these particular terms: menorrhagia, metorrhagia, hypermenorrhea, polymenorrhea, DUBs. And I remember sitting down and learning each and every word of this particular definition for my postgraduate exams. But you would all agree that they're extremely confusing, they're controversial, and they're poorly defined. And we have been lucky that FIGO has now proposed to discard all of them and give us only one single terminology, and that is AUB, which stands for abnormal uterine bleeding. So coming to the definition, abnormal uterine bleeding is defined bleeding from the uterine corpus that is abnormal in duration, volume, frequency, and or regularity. And FIGO underlines that it is to be used when the woman or the adolescent is not pregnant. So to be able to understand what is AUB, we need to know what is a normal menstrual cycle in adolescents. So we know that the menarche takes place at the age of 12 to 13 years. A cycle in an adolescence averages between 21 to 45 days, lasting for 2 to 7 days. The blood loss is about 30 to 40 ml. About 3 years post-menarche, it becomes the same as that of the adult, approximately 21 to 35 days. On an average, an adolescent uses about 3 to 6 pads or tampons per day, and in a cycle, about 10 to 15 pads. And 50% of the total exudate that tends to come out consists of the whole blood components. So having known what is normal, let us now see what is an abnormal uterine bleeding. And this has been given by the FIGO recommendations on the menstrual terminology. When we consider disorders in regularity, if there's no bleeding for 90 days, it is a secondary amenorrhea. When we look at the disorders in frequency, it's considered to be infrequent if there's 1 or 2 episodes in a 90-day period. Frequent, we say if it's more than 4 episodes in a 90-day period. We also talk of disorders in the amount of flow. Very heavy menstrual bleeding, I'm going to be talking about it later on in detail. If it's a heavy or a prolonged, that is excessive blood loss for 8 days or more. Light menstrual bleeding, less than 5 ml is the total blood loss. There are also disorders of duration of flow. If it's more than 8 days, it's a prolonged bleeding. And if it is less than 2 days, it is considered to be shortened menstrual bleeding. But for the adolescents, I felt this particular recommendation of 2023 from the PCOS committee stands better as far as the regularity or the duration is concerned. From menarche to 1 year, we know that all the periods are irregular because of the immature HBO axis. From 1 year to less than 3 years, if the cycle is less than 21 days or more than 45 days, it is supposed to be abnormal uterine bleeding. From 3 years on to perimenopause, it's the same as that of the adults. Less than 21 days or more than 35 days is considered to be abnormal. After 1 year post-menarche, if she does not get her periods for 90 days, it's considered to be secondary amenorrhea, and primary amenorrhea if no periods by the age of 15 or more than 3 years after post-menarche. Now coming to the most important part, and that is the HMB. HMB is the most common clinical presentation of AUB. And HMB's definition does not stand at the amount or the quantity of the blood, but it is defined as excessive menstrual blood loss that interferes with a woman's physical, mental, social, and material quality of life. It's a very holistic definition. And this definition tends to encompass every aspect that this particular heavy menstrual bleeding tends to affect. Now coming on to the etiopathogenesis. We are lucky. Now the FIGO has come on with the classification that is called the palm coin. This is equivalent effective for the adolescent, or we're talking of the adult. There are 2 parts, the palm and the coin. The palm stands for all the structural causes, which can be identified by imaging. And the non-structural causes stands for coin, that's coagulopathy, ovulatory, endometrial, iatrogenic, or not yet classified. How is this classification different in adolescents as well as the adults? We all would agree, since we deal with a lot of adults having AUB, that structural causes, polyps, fibroids, hyperplasia is the most common cause. While in the adolescents, they're extremely rare. They form only 1.3 to 1.7% of all the causes. It is non-structural causes, that is AUB-O, that's all anovulatory cycles. And the second cause is AUB-C, that's the bleeding disorders, which occur in 20% of all the patients for AUB. Hence, when we are investigating or looking at the adolescents, we are looking for the non-structural causes. So to define it and go a bit further, the endocrine causes, that's anovulatory, that's the commonest cause. We have to look for PCOS, the thyroid disorders. The second important cause is the bleeding disorders. 20% of all the girls who come with AUB have got a bleeding disorder, and 33% who have been hospitalized with HMB are known to have a bleeding disorder, of which the von Willebrand is considered to be the commonest. Yes, as we have been talking about, and Dr. Ambuja too has said, that in an adolescent, though pregnancy doesn't fall in the definition of AUB, it's extremely important to be able to rule out pregnancy and to look for the complications associated with pregnancy. Disorders of the uterus, be it congenital uterine anomaly, myoma, polyps, they constitute to be very rare, only 1.3 to 1.7. But yes, we have to look for them if we are not able to find any other particular cause. Infections, cervicitis, and now being sexually active, the STIs as well as the PID. Medications we need to emphasize, because they may be on the contraceptive pills with a pure adherence, they may have taken an eye pill, they may be on Norplans, or they may even be on the hydroxyprogesterone. Trauma. In these girls, because they may be forced sexual activity, they may have been exposed to sexual abuse, so thus we need to take that particular history too. In our context in India, though none of these guidelines do say, is about tuberculosis. We also need to really look for tuberculosis in our girls, whether it's a primary, secondary amenorrhea, it is irregular periods, it's intermittent bleeding. Another aspect that we have recently felt that we need to really look for is the forgotten tampons and the cups. Many times the girls, the adults, they put in a tampon, they forget it, and over a period of time, they develop infection, which leads to intermenstrual or irregular bleeding. So this also forms an important cause for an AUB. ACOG considers AUB in adolescents to be synonymous with anovulatory uterine bleeding. But we need to understand that anovulation is a diagnosis of exclusion, and hence a detailed history, examination, all the investigation should be carried out to rule out all causes of AUB before we label and say that particular adolescent has an anovulatory AUB. This is a very important table that, and a very interesting, I would say, that if the girl gets a menarche less than 12 years, there's a faster maturity of the HBO, and she develops ovulatory cycle within a year. But if she develops menarche after 13 years, it takes nearly 4.5 years for the ovulatory cycles to take place. And this anovulation is predominantly because of the immaturity of the HBO axis. And because of the anovulation that tends to take place, there's no progesterone to support the endometrium. And under the effect of unopposed estrogen, the endometrium becomes very vascular, thick, without a stromal support, and there's a breakthrough bleeding, and sometimes excessive bleeding too takes place. So when we are evaluating a girl or an adolescent for an AUB, we need to look for all the other factors. Our history, our examination, our laboratory investigations are mainly aimed to detect other causes of AUB. And if we are unable to find anything, then we label it to be an anovulatory. So coming to this particular part, which we refer to as evaluation, and starting with certain very good practice points. First of all, how should we take a history? Both the caregiver as well as the adolescent, both should be there, and history should be taken from both. The presence of caregiver is very important, because the adolescent is likely to forget about the menstrual cycles, the amount of blood, about the medical disorders that she's facing, which we can get very good inputs from the caregiver. While we also need to talk to the adolescent separately, because there are certain things that she will not be able to talk, especially the sexual history, the reproductive history. And thus we need to take with both of them separately, spend a lot of time with both of them, and a lot of sensitivity. The second important thing is that irrespective of whether the adolescent agrees to sexual relationship or a sexual history, it is recommended that we should do a pregnancy status, because the adolescents many times do not reveal their sexual history, and we may land up with problems later. Now coming to the most important part, and that's the menstrual history. When we ask an adolescent, how much do you bleed? This is what generally the response we get. What? So we have this beautiful tool which I've picked up from UpToDate. They say you just need to ask these questions. How often do you change your sanitary pad during the peak flow days? How many pads do you use over a cycle? Do you need to change your pads in the night? How large are the clots that you tend to pass? Have you been diagnosed to be anemic? So when we are asking these particular questions, we come to know that if it is a normal volume, then she changes pad not less than 3 hours, less than 21 pads or tampons to be used, seldom needs to get up at night, has clots which are less than 1 inch in size, and is not anemic. If these factors are clear, then she's not having a heavy menstrual bleeding. The ACOG has come up with a little better screening tool. This is from the committee opinion paper, in which, apart from the questions we've already talked, they also ask us to ask, where's the family history of any bleeding disorders? During a dental surgery, did she have excessive blood flow? Was she ever pregnant? Did she have excessive flow after bleeding or miscarriage? And they have said any one of the 4 criteria, that is, the duration of the periods are more than 7 days, and she has a feeling of gush or flooding, and she needs to change pad in less than 2 hours. There's a history of treatment of anemia. There's a history of family bleeding disorders, or if there's a history of excessive bleeding following delivery, miscarriage, or tooth extraction. Any of these, you need to screen them up also for bleeding disorders. This is another way we can get to know how much she's bleeding by using pictorial blood loss assessment chart, where we give 1, 5, and 20 points depending on light, moderate, and severe. And if the point is more than 100, then we consider that the girl is having a heavy menstrual bleeding. Coming to the next important history, that's a sexual history, which we need to take with great sensitivity and confidentiality. We need to ask if she has multiple sexual partners, when is she using any condoms during, because that gives us an idea about the possibility of the STIs, of the possibility of cervicitis, or that of the PID. We also need to ask them about the contraception. They are sometimes advised oral contraceptive pills, which they take it irregularly, have a poor adherence, leading to bleeding off and on. And now there's the IPIL. Invariably, if you do ask them that, have you used an IPIL, you would get many of them saying yes, and they do not know that this leads on to irregular periods. So we need to take that history in detail. Important also is to take history of any medications like aspirin, they are in any antidepressants or anticoagulants or antiplatelet therapies, and past medical histories, which would be liver disease, or we have renal disease or diabetes, or even we consider as an SLE. A brief thing about the review of symptoms, weight change. We need to ask them, have you gained weight in the last few months, or maybe last year, or have you lost a lot of weight? We need to ask them for any galactoria, any visual defects that may be present, any change in hair, skin, or nails. These also give us a rough idea about the various other systemic presentations of the other disease. Family history, bleeding disorders, menstrual disorder, endocrine disorders is important to take. And the last is the social history. I think we need to spend time to ask these, and we get a good idea about how severe is this AUB. Is it really affecting her quality of life? Need to ask about any stresses that she may be having. Is she doing excessive exercise? Is she in anorexia nervosa? Is there a binge eating, excessive vomiting? What about her performance in school? Has the grades come down? Is she taking part in sports? Does she feel tired all the time? This gives us a good idea, because the definition of HMB lies that it affects the quality of life. So we can assess from this how badly is she affected. Physical examination, I know it looks a very busy slide, and all of us in this world at this time, I would say, have started giving less emphasis to physical, but we need to take the weight of the patient. The BMI calculation is important. To look at the breast for the galactoria, we need to look at the skin and the hair, look for signs of acanthus necrosis, a low hairline, very dry skin, which may have been found to present, any abdominal mass that may be found to be there. A Tanner staging is extremely important in adolescent. What about doing an external examination? The genitalia should be examined externally, especially if you're talking of irregular intermittent bleeding. Whether to do a PS or a PD. Now, this is a very controversial area, and it should only be done as and when indicated by the history, and as if we are suspecting that she may have a tampon inside or foreign body inside, or if she complains something suggestive of STIs. Coming to the last aspect, and that is the laboratory evaluation. A whole battery of tests does not need to be done. We need to do tests depending upon the history and examination. So pregnancy tests, the first, need to rule out anemia, so hemoglobin, hematocrit with platelet count, and serum ferritin. We need to rule out hypothyroidism, so TSH, bleeding disorders, PT, APTT, serum prolactin if galactoria, screen for STIs if she has a sexual history or symptoms are suggestive, and if hirsute, investigate for PCS. Whether a pelvic ultrasonography should be done or not, we had a great discussion in a hospital based on that, while many of the gynecologists felt that once a girl is coming in with the HMB, we should be doing an ultrasound for the particular patient. But if you look at the committee paper, it says the routine ultrasound should not be solely done for workup. It should be done only if it is indicated, that is, you feel there's a failure of the treatment, pregnancy is suspected, or you suspect some structural defects of the uterus. And transabdominal ultrasound is preferable if she's not sexually active, but if she does give, then definitely a transvaginal ultrasound should be done. As we said, that the bleeding disorders form 20% of them, and the commonest of them is a von Willebrand disease. But the question is, should we screen all the girls who come to our clinic with HMB for the bleeding disorders? We say that if one of these 4 factors are present, any one of them, then definitely we should screen. That is duration more than 7 days, history of anemia, family history, and excessive bleeding retraction, which I had already stated. We need to realize that whenever they have a bleeding disorder, at Menarche, very fast bleeding is found to be excessive. That is how many times it's diagnosed. They sometimes present with recurrent CL cyst. Each time they have an ovulation, they land up with a hemoperitoneum. That also tends to tell us that maybe this particular girl may be having a bleeding disorder. And the first line of investigations we need to do for the bleeding disorders is to do a von Willebrand's antigen, a von Willebrand resultant cofactor activity and factor 8. Any further, the second or the third line should be done along with the hematologist, because we ourselves will not be able to go that much. Main good practice points as far as this is concerned, those with the blood group O will have a lower level of the antigen. And thus we should use the reference levels according to each patient's blood group. Secondly, the testing should not be done either before or 7 days after. It should be done only either before starting the estrogen therapy or 7 days after cessation of estrogen therapy, because estrogen replacement therapy has known to alter the plasma von Willebrand factor antigen. Now, putting all of this into a diagnostic approach, that is the basic approach how we need to take it. So first of all, let's say a girl has come to me with an irregular bleeding. I'm going to ask her age. Is she very near menarche? Is she within 1 to 3 years of menarche? Is there any signs of premenstrual syndromes? If these are not there, since anovulatory is the first cause, that's going to come. If she's obese, she's got signs of hyperandrogenism, the PCOS is what I'm going to think. And these 2 are the most common causes. The less common causes, weight gain, weight loss, heat to cold intolerance. There's a family history of thyroid. I think maybe she has hyperthyroidism. Going for a thyroid profile. Galactoria on my examination, look for prolactin. If she gives history of pure nutrition, excessive exercise, a lot of psychological stresses, maybe it's a hypogonadism, do an FSH-LH. And in case we do get features of STI and a history of STI, look at the external genitalia and do an STI screening. Those who come to us with regular periods but have an excessive flow, the first thing I would like to think, is it a bleeding disorder? Take a detailed history about the family, easy bruising, gum bleeding, bleeding after surgery. Less common causes, is she on any medications, anticoagulant therapy, antiplatelet therapy, hypo or hypothyroidism, and look for structural causes, maybe a polyp, a fibroid, dysmenorrhea, maybe sometimes endometriosis, and that's where a pelvic ultrasonography may be indicated. Regular menses, yet in between she has spotting. She may be on some of the hormonal contraceptives, she may have taken an IPIL, she may have an IUCD. There may be poor adherence or maybe recent initiation, and we need to look for the STIs. It's also important in the ones who are sexually active to look for ectropions, to look for cervical polyps. And the girls, if they are extremely feel that they may have any history of trauma, that's a forceps, a renal injury, look at the external genitalia. So coming to the end, I would say that it's important that we all decide individually and learn that AUB accounts for half of all the gynecological problems, and it's extremely important to evaluate every adolescent and ask every adolescent. They never come out themselves that they're having heavy periods. It's important for us, when they do come for any reason, to inquire how is the bleeding and how's the pattern. HMB is the commonest presentation, and ovulation is the commonest cause of AUB. And bleeding disorder is the second more common. And in our country, we need to think also of tuberculosis as a cause of AUB. A clinical and symptomatic based approach should be added to our diagnosis, a detailed history, and a physical examination, which we all have started skipping. This is something that we really need to take because maximum pointers come from this, and that is how we need to conduct our laboratory investigations. So I would like to end by this particular little quote. And in the end, this quote says, a grove cannot be made by a single tree. And similarly, the future of a nation cannot be made by one child. We have to have so many more young, youthful women with strong mental and physical health. And as gynecologists, as leaders, it's our responsibility to ensure that these adolescents, through a good health and a mental status, fill up to become this microgrowth. Thank you so much.
First of all, I would like to congratulate you for a wonderful talk. Thank you so much. You have thoroughly covered all the small points regarding history, examination, as well as investigations. Wonderful.
Thanks. Thanks.
I just want to tell Dr. Jyoti, I think you covered almost every aspect in a very, very beautiful manner. Nowadays we are having always one of the common thing is when a young girl comes, who should see her? Whether pediatrician should see her or a gynecologist should see her. This is always a confusion, and I think the best is to start a department of adolescent now. What is your opinion?
I think they will come to gynecologist always, being female.
So definitely now it's a world of a multidisciplinary approach. So if you are coming at that particular time, I think it would be very good if we have these health clinics where we have an pediatrician, we have got a gynecologist, we have an ultrasonologist, a physiotherapist, and a dietitian, so we can have a combined approach altogether. So that would be something we're looking for in future.
There are not many questions. Here. Can I just add something to Dr. Jyoti? You spoke so well. I mean, there's nothing that left that one could add on, but what you just now said, we have developed these adolescent-friendly health centers. And when I was a chairperson, it was, established in Delhi. The first place was Max Hospital. And I think Sakhare Hospital has it. So as you correctly said, these are the centers where holistically we deal with all aspects of, issues. And very well said, it's only with the gynecologists that we deal with them. So I would like Dr. Jyoti, since you're in charge of the Adolescent Committee in Delhi, if you can look into these centers, friendly centers, I'm sure you can do a great job there. Very well done. Congratulations. I'll be in touch with you. Thank you.
Yeah, thank you, Rajez.
There are no other questions, but I just want to add a few things. Now the biggest problem in India is education of both adolescent as well as the mother. And many of the times these people, they come for some irregular, they come running and, the definitions of terminologies have changed, and still people are using the old, and they say that it is abnormal, and they start treating these young girls. And what do you say about the school education part of it? Do you think that is it now doing everywhere in every school, or is it that only foxy people are doing, or how is it?
Dr. Rajesh, yes, as an adolescent committee member, we are making a huge effort to go on to every school and reach them out. But yes, I feel now, having gone to many schools, the principals and the teachers too are trying to actually from their side spread this particular method, but they do not have a curriculum specifically towards the sexual health as well as this health. So that needs still to be ingrained and put into the schools. They do not have a curriculum, and they themselves are very reluctant to talk to the children. So we actually need to educate the teachers how to get over the inhibitions, how to get over there so that they can start speaking. Children are very easy to ask. Whenever we have an interactive section, I think the children are coming with questions one after the other. But yes, it's the teachers who are very reluctant to answer. So it's their way we need to really work, not on the students.
And lastly, one of the commonest problem nowadays is any girl goes, they ask for an ultrasound. and ultrasound invariably comes as PCO. This is one of the commonest mistake I feel most of the people do, and they start treating them with all sorts of medications and other things. I think this is what is your opinion with this? And you very rightly highlighted that ultrasound is only required whenever it is required, only you should do.
So, sir, I do agree with you 100%, but now we have the international PCOS, which says for the 8 years after menarche, you do not do an ultrasound. The ultrasound criteria is not included in PCOS. So to be able to diagnose PCOS based on ultrasound, that's totally out. And I think that is what we all have to educate our fellow friends, that do not do ultrasound. That's not a criteria for PCOS. And the ultrasound that we do, it's per abdomen, where the penetration may be less. These are obese patients. We do not get a perfect picture. And the radiologist also do write in PCOS morphology. They will not say the volume. They do not have a look at the volume. They do not have a look at the number of eggs. They just say PCOS morphology, and they're started to be treated. So this is something that has to be changed.
I think, we need to do our own scans. We need to learn to do our own scans.
Yes. I think, Madam, you beautifully covered the whole, etiopathogenesis and diagnosis in a very short time given, and very, very clearly. And you highlighted many of the aspects of, even the simple terminology and so many questionnaires. I think beautifully done. Thank you for putting all this thing within a span of 20 minutes. Thank you. There are no other questions, I hope, Dr. Asha.
Thank you, Dr. Jyoti. Thank you, sir. Thank you, Rajesh, sir.
Thank you for the opportunity, Dr. Asha, for giving.
Thank you for being here, sir. Thank you so much.
And wish you all the best. And there are many other who I know them from long time, but since I am not in picture for many years, I have not seen them. Rosa and Harish, thank you very much. Bye.
Thank you, sir. So now,
best of luck, Dr. Asha.
Thank you, ma'am. Thank you so much. Thank you. Now, I would like to introduce the chairpersons of the second session. Dr. M. Chandra Ponnusamy. Ma'am is a UG PG in Government Stanley Medical College, Chennai. She's a gold medalist. She's the first laparoscopic and IVF center of her district, that is Namakkal, and delivered the first IVF baby and ICSI baby of her district. Ma'am received the Tapesav Dronacharya Award in 2023 and Distinguished Stanleyan Award 2024. She is the founder president of Namakkal Society, and she's been kind enough to always come in whenever I call her. So welcome, ma'am, to this forum. We are really honored to have you. We have Dr. Anil Sakhare, sir. Again, his forte is vaginal surgery. He's worked at GMC Nanded for 11 years. UG and PG teacher, examiner, has many publications. And he has contributed in the Williams textbook of obstetrics. He's contributed in the International Reference Book of Operative Obstetrics by Cunningham, served in African countries, operated hundreds of cases through Rotary medical health camps. He has done more than 7,000 NDVH cases and has very many awards. Welcome, Anil Sakhare, sir, to this forum. We also have Dr. Gopal Kalita, President of Nalbadi Obstetric Gynec Society, Director of Sushrusa Hospital, Nalbadi, Assam, Senior Consultant, Department of Obstetrics and Gynae for the last 26 years, special interest in obstetrics, infertility, and gynec laparoscopy. I'm not sure he has been able to join because there was some function going on in his college. So over to you, ma'am, Chandra ma'am, to please introduce our speaker, Dr. Jyotsna Suri ma'am, who's kindly agreed to talk.
Good evening, everybody. Good evening, all the dignitaries. And at the outset, I would like to thank Dr. Asha and for making us to interact with each other. Without this webinar and all, people from logicians from one side of the south from India, we cannot interact with the people of west, north, and east. So it's a good thing you're done, and I'm congratulating you for this wonderful webinar. And it's my pleasure to introduce Dr. Jyotsna. She's a professor and unit head in charge of critical care obstetrics, Sadarjung Hospital, Delhi. And she was the vice president AOGD in 21-22. And she was the national corresponding editor, Jogi 21, still doing that. And chairperson of Safe Motherhood Committee, AGOD. Then again, she was the chairperson, multidisciplinary committee of AGOD for 2016 to 18. And she has edited and co-authored book Practical Approach to Clinical Care in Obstetrics. And she has delivered more than 200 guest lectures in international, national, and state conferences conducted, several critical care obstetric workshops. And she was awarded WHO Fellowship in Reproductive Endocrinology in 2009. And she was awarded CS Dawn Prize for Best Paper in ACOG. And she was a recipient of APJ Abdul Kalam Appreciation Award and also recipient of Academician of the Year Award conferred by DGF 2021. And she was the recipient of APJ Abdul Kalam Excellence in Teaching Award 2022. And she is the principal investigator, Action 3, World Health Organization Trial and ICMR project on screening for GDM. And we are happy to have you here. And please, you can proceed, Dr. Jyotsna.
Thank you, Madam, for the kind introduction. I would, at the outset, like to thank Dr. Asha Jain, Madam, for inviting me and giving me this opportunity to be with all the dignitaries here today and the dear delegates to talk on this important subject. So I'll share my screen straight away. Yeah, I hope it is visible.
Yes, very much visible.
Okay, thank you, Madam. So, as was being discussed by my dear friend, Dr. Jyoti Bhaskar, yes, we were talking about the special clinics. So yes, Safdarjung Hospital was one of the first clinic, as Dr. Rosa said, to have the adolescent friendly, services. And also we have a multidisciplinary clinic, with the involvement of the obstetrician and gynecologist is there, along with the pediatrician and our psychiatry colleagues. So this is, going on for a very long time. The adolescent girls come, and even boys, they come without any, feeling of being judged, or, they come confidently and talk about their problems in this clinic. So coming to my topic about the management of adolescent AUB. So with such a beautiful introduction of the topic has already been given by Dr. Jyoti Bhaskar about how to evaluate these young girls. So I will talk about the management. And since heavy menstrual bleeding is the part which is most, critical in the management of the AUB. So, in the short time, I will be focusing mainly about the heavy menstrual bleeding in adolescent, even though AUB is a wide term which encompasses even the other things like irregular bleeding, absence of bleeding. So, everything we will not be able to cover. So coming to the management of the heavy menstrual bleeding in the adolescent. So what are the goals of management? So it is, we have to stabilize, first of all, any hemodynamic instability if they are having acute bleeding, control the bleeding, treat the anemia, establish a regular cyclic bleeding for them, and prevent long-term complications of anovulation, which would result in anemia, endometrial hyperplasias, and even endometrial cancers. So when we categorize the AUB for the management purposes, so we can categorize it into mild, moderate, severe, and critical. When we say it is a mild heavy menstrual bleeding, it is, the patient, the girl will come with her guardian or her mother. She may, give history of mildly excessive bleeding, which may be more than 7 days and less than 24-day cycles. And this is for a period of at least 2 months, because one isolated cycle, we will not think, it to be very alarming. And hemoglobin will be normal. So here, this is a girl who is come to us to our clinic. So it is very important that, this opportunity we should not lose and let her become, into the next stage of moderate or severe. So the second is the moderate. So moderately prolonged would be more than 7 days or frequent menses every 1 to 3 weeks. And again, in this moderate flow, the patient still is maintaining her hemoglobin of more than or equal to 10 gram. Severe is a condition when there is a disruptive menstrual cycle in which, the cyclic pattern is practically gone, and she's come with heavy bleeding that has also caused a decrease in her hemoglobin to less than 10 gram. And she may or may not have hemodynamic instability. But critical is when there is any hemodynamic instability, she is having tachycardia, she is having low BP, the shock index may be more than 1 or 1.1. And also she may be having a hemoglobin less than 7 gram, or she may not be, so a very girl who is at a baseline. So a girl who is there some echoing? Hello? Yeah. So a girl who is having a a baseline of say 12 gram or 13 gram, if she bleeds for a month, she may not become less than 7 gram. But in case she is having very heavy bleeding with hemodynamic instability, even with a hemoglobin of more than 7, we have to take it as a critical case. So in all these girls, medical management is the treatment of choice unless it is a exceptional circumstances, which I'll talk about. So what are the indications of admission? First of all, as I said, any hemodynamic instability, even, picking up things like orthostatic hypotension. So patient may have, when she's sitting, she may be having a normal BP, but as she, the vital signs on lying down and then getting up, so all these are very critical early signs which we are to see. Severe anemia, less than 7 gram, and need for blood transfusion. Symptomatic anemia with fatigue and lethargy. Need for IV estrogen. So if there is continued heavy bleeding, you have sent her to home with, estrogen progesterone combination therapy, and patient is still heavily bleeding for 24 hours or more, then you may need to admit her. And of course, if you have planned for any surgical intervention. So the critical interventions, once you admit your this young girl, you may need to give the fluid resuscitation in the crystalloids as well as sometimes the colloids, oxygenate the patient, blood transfusion if the hemoglobin is less than 7 gram, or there is any hemodynamic instability. And sometimes even the products, if there is a bleeding disorder with severe thrombocytopenia, or there is a coagulation effect, so we may need to give urgent product transfusion. And of course, very important, which I have put in the capital letters, is the urgent control of bleeding, where our most important role of the gynecologist is there. Of course, Dr. Jyoti Bhaskar has already detailed that how we would evaluate this kind of case. So, how would we control the hemorrhage? What is the first line? So, is it only estrogens? Is it only progestins? Estrogens plus progestins, tranexamic acid, mefenamic acid. So, what would be the first line for control of the hemorrhage? And I think all of us are on the same page when we say that estrogen and progestin, that is the combined OC pills, are the first line for managing acute bleeding in the adolescents. So which COC is the best? A monophasic preparation containing 30 to 50 microgram in combination with levonorgestrel or norethistérone. So levonorgestrel, which is a second generation progesterone, is generally considered to be superior to the first generation, which is the norethistérone. And this is generally considered as the first line option because it stabilizes the endometrium. And with levonorgestrel, the chance of breakthrough bleeding is also lesser because it is more potent than the first generation, that is the norethistérone. And you need at least 30 microgram or more. So when there is a acute bleeding, less than 30 microgram is not considered suitable. So it is always 30 to 50 microgram. Some of us would even prefer to give a 50 microgram directly rather than 30 microgram. Exogenous estrogen permits additional endometrial proliferation, which heals the sites of endometrial bleeding and provides hemostasis. So therefore, important is that we always give a combined COC, combined estrogen and progesterone rather than giving progesterones alone because of the healing property of the estrogen. Whereas the progestin stabilizes the endometrial lining. So both the components are very important if we need to establish the hemostasis as fast as possible. So continuing on the hormonal therapy, some other important points about it. There is a concern amongst our colleagues that if the girl is young, she's an adolescent girl, giving her estrogens may impair her vertical growth. So this point, I want to stress here that evidence shows that by the time a girl achieves menarche, most of them have completed 95% of their growth. So concerns about the use of estrogen and closure of epiphyseal plates should not preclude hormonal therapy in the treatment of heavy menstrual bleeding. So what you are dealing with here is a critical situation where you are seeing the girl is becoming anemic by bleeding heavily and vis-a-vis the 5% of her growth which is left. So if we are to be in this situation, any day we should be, treating the girl and preventing the girl from becoming anemic and bleeding, to that extent. So this concern, I think, should not be the primary for us at that moment. The first line monophasic combined OCP, as I told you, are the drug of choice, and we should start them every 6 to 8 hours until the bleeding stops. So normally giving it once a day would not help in the acute bleeding situation. We need to give a higher dose. So we can give it every 6 to 8 hours. So normally we start it 3 times a day. And then once the bleeding has stopped, which takes about, normally it will take minimum of 24 hours, but sometimes it may take up to 48 hours. After that, you can start a tapering of the OCP. So if you can taper it for a BD dose for at least, another 48 hours, and then continue it in the OD dose for minimum of 21 days. But if she is still anemic at the end of 21 days, we can continue till the anemia resolves. We don't want a withdrawal bleeding till the girl has, recovered from the anemia. So this is very, very important that whatever good we have done by letting her having another heavy bleed, all the thing will become undone. So that is very important. And when we are giving this OCP in the, 3 times a day or 2 times a day, she is likely to have nausea, at times even vomiting. So we have to and should, at least during the first 3-4 days when we are giving the high dose, add antiemetic along with the OC prescription. If the bleeding has not stopped or significantly improved within 48 hours, we should consider the IV therapy, and also a hematologist should be contacted, because then we may be dealing with a bleeding disorder, which of course, evaluation of that side by side we have to continue doing when the girl presents with such heavy bleeding leading to severe anemia. So contraindication to the COCs are the migraine with aura, the venous or arterial, both thromboembolism, history of any such event in the past if the girl has had, If she is hypertensive, there is an acute liver failure, congenital heart disease. So these are some of the important causes in which we cannot give a estrogen containing preparation, where we will then have to rely only on the progesterone, which definitely is not the drug of first choice, but then it will have to be chosen because of the contraindication to the estrogen. So the indications of IV estrogen are when the patient with severe anovulatory uterine bleeding is unstable and cannot take oral medication. So if she is that sick that she is not able to take a oral medication, if bleeding is not controlled after 24 hours of our combined hormonal therapy, then we should consider the IV estrogen. The dose is 25 milligram every 4 to 6 hours until the bleeding stops. And we should not be giving more than 6 doses, because this itself, giving IV estrogen can, have a potential complication of thromboembolism. So mostly within 3 to 4 doses, the bleeding is controlled. And after that, we can start the COCs as I discussed previously. So this is very important, that we can't keep giving, more than 6 doses. After the bleeding subsides, the patient should be switched to a taper of combination of monophasic oral contraceptive. So what I discussed, that if there is a contraindication to any estrogen, giving the estrogen preparation, so then progesterone only therapy is given for the cessation of bleeding. What are the drugs we can use? The first drug would be the oral medroxyprogesterone, 10 to 20 milligram every 6 to 12 hours, or norethindrone acetate or norethisterone, 5 to 10 milligram every 6 to 8 hours. But here the important thing is that norethisterone is metabolized to ethinyl estradiol. And if you give 5 milligram TDS dose, about 20 microgram of ethinyl estradiol is released. So if the girl is, having a contraindication to estrogen, then we should avoid the norethisterone, and oral medroxyprogesterone would be the drug of choice. So these are, this is from the ACOG 2019, in which the medical treatment for heavy menstrual bleeding, this is the table I have picked up from there. So you can see the doses as we have already discussed: 25 milligram IV, 4 to 6 hours for 24 hours. And the COC, which they have said 30 to 50 microgram ethinyl estradiol containing, as we discussed again, 6 to 8 hourly. And medroxyprogesterone acetate is the progesterone they have recommended, 20 milligram, 3 times per day for 7 days. And then, of course, you can start tapering it. And tranexamic acid. So I will talk about the tranexamic acid little later. So these are the normal common formulations of COC which are available. I've just put a few of them, but I have highlighted the 30 microgram and LNG, which is, in the government supply, free of cost, and at a subsidized rate, the Mala D is available. So I think this is the first one, is the drug which for any adolescent who is heavily bleeding, Mala N or Mala D fulfills, the criteria, because you have to give it 3 times a day. So I would not choose a, preparation with drospirenone, because then we would go into giving a very high dose of drospirenone 3 times a day, would make it 9 milligram. So these drugs, are not, we don't have much evidence about these high doses with other progestins. So LNG would remain the best choice when we have to give a higher dose, as in a acutely bleeding adolescent girl. The addition of hemostatic therapy to hormonal therapy may be warranted for severe anovulatory uterine bleeding that continues after 24 hours of hormonal therapy, and in patients with platelet dysfunction. So this is again, the ACOG 2019 recommendation that we should add it if the girl is not, recovering after 24 hours of the hormonal therapy. So why don't we give it straight away? So actually the thing is that the tranexamic acid has a thrombogenic potential, and COCs are also thrombogenic. So the concern is that using antifibrinolytics such as tranexamic acid concurrent with OC. In the tranexamic acid literature, it is written that prescribing information, it is written that concurrent use of OCs should not be given because of the theoretical risk of thrombosis. So even though this has been written, the concomitant administration of tranexamic acid and OCs has been used when the monotherapy has failed, and ACOG labels it as a reasonable approach to management when other options fail. So we are not giving it together. So first we give the COC. If the patient is not responding after 24 hours, it is reasonable to add the tranexamic acid. And if there is a platelet dysfunction, we can add it earlier also. So the other, besides the tranexamic acid, which the dose I already discussed, you can give 500 milligram to 1 gram 8 hourly. So other hemostatic drugs are the aminocaproic acid, which normally we are not giving. It is the tranexamic acid, which is, very commonly given. And the other drug is the desmopressin, especially if there is a bleeding disorder. This drug is also found to be very useful. We should always give it in consultation with our hematology, colleague or a physician. So 0.3 microgram per kg IV over 15 to 30 minutes is the dose, which may be repeated in 48 hours if there is no response. And after this acute event of bleeding is controlled, so what is the long-term management? So after correction of the heavy menstrual bleeding, maintenance hormonal therapy can include combined oral contraceptive pills for at least 6 months. We can also put the girl on oral or injectable progestins, and the other option is the LNG IUD if there is a desire for contraception also. So this is what the ACOG recommends. Now coming to the maintenance therapy. So, what are whom should be put on estrogen and whom on the, not estrogen, combined estrogen progesterone, and whom on the progesterone. So very, very, I think, logical statement would be that in those who were initially controlled on the estrogen containing drug, continue the COC with, ethinyl estradiol of 30 microgram, the pill should be having for 3 months. And if there is a breakthrough bleeding, doubling the dose of the combined OC until the bleeding stops may be preferable to allow a withdrawal bleed rather than to allow a withdrawal, because she's still anemic. When the hemoglobin is more than 10 gram, then we switch to a 21-day cycle and continue this COC for 6 months. So start it, continue till she is, at least having a hemoglobin of 10 gram, continue the COC up to 3 months or up to the 10 gram, whichever is earlier, and then give her a withdrawal bleed and then continue for 6 months more. In those whom we had not given the estrogen due to any, she could not tolerate, there was nausea, vomiting, or she has a contraindication for estrogen. So in those cases, we can start her on cyclic norethistérone 5 milligram OD for 5 to 10 days each month, or cyclic micronized progesterone 200 milligram OD for 12 days each month, or the medroxyprogesterone acetate 10 milligram OD for 10 days each month. So the calendar, 1st to 10th of the month, the girl can be told to take this for at least 6 months, because this is the maintenance therapy. If we do not give it, she will again come with heavy bleeding and again become anemic. So this is the, maintenance therapy, which has to, actually we have to stress on this, because it is very, very important that till her, it is our, this 6 month, we hope that her HPO axis will become more mature and she may start having the, regular ovulation and anovulatory cycles will, finish. So that is why we will give her for 6 months at least. So for the preferred, progesterones, I've already told you about this. So continuing with the long-term management, these girls should be counseled that weight gain is not associated with the combined OC, but some fluid retention can be there. And it is important that the BP should be checked prior to initiation and annually for all girls who are taking the combined hormonal contraceptive pills. BMI is very important again, because we know that having a more than 35 BMI again is a relative contraindication, and we have to be careful in the adolescent girls who are having morbid obesity. Iron supplementation should continue till the ferritin level. So it is not just the hemoglobin which we are looking at. We have to see that her stores are also replenished. So once her ferritin level comes back into the normal range, we will continue the iron supplementation. And as I told you already, we will continue the hormonal therapy for 6 months. Then we stop to see if the normal cycles have resumed. And in this time, we have to strictly maintain the menstrual calendar and call her for follow-up. So again, after 6 months, when we stop, if there is still the similar episodes of heavy bleeding, we need to restart the hormonal therapy. For girls who desire contraception, we can continue the COC even after 6 months. And now, I had already in the beginning, I had categorized mild, moderate, severe, and critical AUB. So now if the bleeding is only mild, so
Jyotsna ma'am,
yes, madam.
please speed it up.
Yes.
Yeah. Okay. Just I think these are 1 or 2 last slides. So here, mild to moderate, we have to just give the reassurance, give her the iron. And in these cases, if you think the girl is, having a quality of life issue with the heavy bleeding, which she perceives, we should, consider it. We may prescribe the OC pill to her. Moderate, if she's not bleeding at present, you can, put her on the COC or the cyclic progesterone and also give the iron. But if there is a heavy bleeding episode, we will manage the way I have already told you. For those who do not desire hormones, the tablet tranexamic acid during the first few days when she is having heavy cycle should be recommended. So this is about the non-hormonal therapy, the NSAIDs and the tranexamic acid, which I had already discussed. This is especially for the mild to moderate, bleeding. They can be given this. And NSAID, I must tell that if there is any platelet disorder, we do not give NSAID. So we have to be careful that those who are having any bleeding disorder don't give NSAIDs to them. And we can give them continuous or extended cycle of hormonal contraception. And if there is a breakthrough bleeding, then double the dose, as I already discussed. And in these girls, we should always manage them with the hematologist. And desmopressin is a very good drug in the von Willebrand disease. It is available both in intranasal formulation as well as IV and subcutaneous. So these are the very important drugs for the bleeding disorder. Surgical management is exception, and only if the patient is not responding to medical management, and you have to then do a ultrasound, which normally we are not doing, and you see there is very thick endometrium or clot in the cavity. So here, this is very, very exceptionally and not a norm at all. Let me stress again and again. So you may need to, do a very, very rarely suction evacuation or a curettage. And then other method is the Foley bulb inflation. You can use the 30 cc bulb for inflation for 24 hours till the medical management, start takes effect, and then we can deflate the bulb and take it out. So the PCOS, which Dr. Jyoti has already discussed. So the irregular menstrual cycle, if the girl is not having regular cycles till 2 years, post menarche, we are not worried. But in the 3rd year onward, with hirsutism, you can think about, that she may be at risk for PCOS. So here again, the hormonal therapy is the thing very important, so that she doesn't have endometrial hyperplasia and other risks of, not having the regular cycles. So anovulation is a very important risk factor, which later on can lead to problems for the girl. So the key points of this talk here, that hormonal treatment is the first line for moderate as well as severe AUB in adolescents. Since bleeding disorders are the second most common cause of adolescent AUB, evaluation by hematologist is important, especially in the refractory cases, and treat according to the etiology in these cases, of course, along with the hormones. COCs are the drug of choice unless there is a contraindication for estrogens. Minimum 30 microgram of ethinyl estradiol is advocated. Consider continuous COC for 3 months till hemoglobin is more than 10 gram. Continue treatment for at least 6 months till the HPO maturity takes place and the anovulation subsides. Absence of regular cycles after 2 years post-menarche till 19 years with hyperandrogenism becomes at risk for PCOS. So here again, we have to consider the hormonal therapy for them along with the lifestyle interventions. So thank you very much for the patient hearing. And I think I have overstepped my time. I'm sorry for that.
Yeah, thank you, Dr. Jyotsna, for your elaborate talk. And of late, I think 8 years post-menarche, after that only we consider PCOS, no?
Yes. So till then we say they are at risk, but we should not label them as PCOS.
Yes, and then is one question in the chat box. What is the percentage of IV estrogen in your practice?
Yes, so I think it's a very important question. I have only given to one, there has been only one patient who did not respond to the COC and we had to give IV estrogen, but it is not something which we use commonly. It is not, most of them do respond to the COCs.
Dr. Jayabharti ma'am, welcome to this forum. We would love to see you and hear your interaction to this. Dr. Jayabharti ma'am.
Hello.
Yeah.
Thank you, Dr. Asha. My question was already asked. It has been asked and answered all. Thank you. Thank you for that.
Thank you.
Thank you, Dr. Asha, for this excellent opportunity for myself and for my society to take part in this webinar. And I wish you all the best for your candidature. And we'll proceed with this panel.
Thank you, ma'am. Ma'am, I request you to stay on, please. My panelists are just messaging me that, you know, we are in an emergency and I see only 2 of my panelists here. So please requesting you to be on.
Yes, yes.
Dr. Jyotsna, ma'am, if you can spare the time, I would love to have you.
Yes, ma'am. Okay, I'll be there. I'll be around here. Yes.
Yeah, because I've taken case situations and so, namaskar. The panel today is an adolescent AUB. That's me requesting you to vote for me for chairperson for drug committee. My panelists are Dr. Rashmi Ajith. Suddenly her mother had an emergency. Dr. Pooja is joining. Dr. Dipjyoti Das. Pooja is secretary of Nanded Obstetric Gynec Society. Dr. Dipjyoti Das sir is with us. He is the secretary of Nalbadi Obstetric Gynec Society. Dr. Nalini Katta is a consultant obstetrician and lab surgeon from Bhimavaram. And Dr. Nirupama Palakode is senior consultant Sri Gautami Nursing Home Bhimavaram. Dr. Geeta Mekot also got caught up in an emergency. She is from the president from Kannanur Society. I also welcome Chandra ma'am to be with us and Dr. Jyotsna to deal with the problems that we might be having.
Yes.
So this is the chapter from which I have taken most of my situations. All this has been covered in very great detail by both our speakers. So I'm just running it through. I'm not going to talk about it. And we will do the panel as a rapid fire case. Dr. Dipjyoti, sir?
Yes,
And
ma'am.
Nalini. Yes, sir. Requesting you to please put on your video and, we take it fast. So there's a 15-year-old girl who comes with bleeding per vaginum for 2 months. She has a BMI of 21 and has had her first period at 13 years of age. Periods were very regular, 5-6 days of bleeding every 28 to 35 days from the beginning. This time she has a bleeding for 2 months continuously. So what is the relevant history that you want to ask here? Das, sir? Yes, sir.
Am I audible, ma'am?
Yes, sir. Yes, sir. You're audible.
Actually, I am a very
What is the history that you want to ask here? I mean, she had very regular cycles and suddenly at 15 years, she's coming with 2 months of bleeding. Dr. Pooja?
Ma'am, was there in this period was preceded by like amenorrhea?
Yes.
Be pregnant or is there any kind of amenorrhea followed by bleeding PV? And whether she is having sudden weight gain or during this period, and as her BMI is high, and whether she is having any thyroid disorder.
She has a BMI
Normal.
of 21, which is
Yes, it
absolutely
is.
normal.
Yeah, it is normal. Sorry. I read it 25. Okay.
So you have asked her the history of amenorrhea, right? Why do you
Yes.
want to ask amenorrhea? She had periods at the age of 13. For 2 years, they've been absolutely normal. And now suddenly she has amenorrhea of, she is coming to you bleeding for 2 months. Chandra?
Yes, she has been regularly menstruating till now, and her body weight BMI is normal and that everything is apt. So I want to ask whether she had any dental extraction or anything, and whether she has any fatigue or malaise after this. But this looks like first episode of bleeding disorder for me, but it has been continuous. So whether it is associated with any pain symptoms or it is a painless bleeding like that, and whether family history may be helpful in this case. And
Dr. Nalini?
I think she should be asked for any sexual relation with somebody.
Yes,
We have to ask
that is
for.
very important. The thing is, we are not thinking about it, and the girls are not telling about it.
Yes.
Right?
Yes.
So, yes, Dr. Nalini, what will
Yes,
you
ma'am.
answer? What examination are you going to do?
I will examine first the vagina. I will examine the genitalia. Are there any bruises or rashes? And I want to see where the bleeding is coming from. Is it from the vagina or any other part in the external genitalia, ma'am? If there is an assault, there will be evidence of it will be seen, ma'am.
So actually, Dr. Dipjyoti Das
I-
was the one
I
who
want
gave
to,
the
I
correct
want to,
answer here.
I want to gain her confidence separately, separately from their parents, and I will become a friend at that time. And if she suppose mention something about the relation, then only I go for urine examination first.
Okay. So when we took her history,
Pregnancy.
she said that she had conceived, her pregnancy tests were positive, and her boyfriend got her a pill and she took that pill, and she has been bleeding since then.
Yeah.
Now, what are you going to do?
Next, we have to.
What investigations do you want to do now?
Ultrasonography, madam.
ultrasonography.
First of all, ultrasonography, madam. Complete blood picture
Check
and whether
look
there are
for
any
two
RPO.
different kinds of investigations. One is to see her clinical condition, and
Yes.
the next is to treat the cause. right?
Yeah.
Yes.
So like Chandra ma'am was saying that
Complete
whether
picture.
she's breathless, whether she's getting tired. So the status of her anemia.
Yeah.
That. And the second, then the next is the treatment. So what all are you going to advise?
Complete blood picture.
And
Crop
comes under this POXO Act, no? First of all, she is
yes.
15 years.
Yes.
So first it should come into our mind, and who has brought her to the clinic, if it is her a parent or guardian, then we have to tell them, and we have to report it to the...
So she has come with her boyfriend. Okay.
But it is not possible. It is not easy to get tested for urine.
No, so you will test her for urine.
Yes.
And as Dr. Pooja said, we'll do an ultrasound. Okay. Now she has retained products. A lot of retained products are there. So now the thing is you need to evacuate those products.
Yes.
And you also need to take care of her anemia. Right?
Yes.
So are you going to inform her parents or you're not going to inform her parents?
Definitely.
We are definitely going to inform her parents, ma'am, as she's minor. She's just 15 years old.
Okay, if she tells you that if you inform my parents, I'll run away. I don't want treatment from you. What are you going to do?
So we have to admit her, get the consent, because then we have to inform the police, then we have to start treatment, hospitalize her and stabilize her, and we have to make it ready for evacuation.
Agreed.
She runs away. As this case comes under POXO, should we not inform police like this so-and-so patient has come to the OPD with this kind of complaints? She was pregnant and she ran away.
So what you have to do, will you inform the patients? It depends on the will of the patient. One. Now, if she has come with her boyfriend and that boyfriend is 18 years old, right?
But we need a sign of a guardian, no?
Yeah. And how do you define a guardian?
We must communicate with
He's
police.
18 years means then he automatically becomes a guardian and he can give consent.
Exactly, ma'am. This is the point I wanted to bring up, that if the boyfriend is a major, he himself can act as a guardian and give consent. Only thing is we also need to take all his details. Now, what additional? You have informed the police. Now you have performed the evacuation. You've given her 2 units of blood. She says she's going to continue with the physical relationship. Will you give her oral contraceptive pills or any contraceptive advice?
First of all, we'll counsel her that in this age, lot of regarding this STIs and other things, we have to tell her, we have to counsel her. Then, because she is going to continue, definitely we have to give her contraception. That's understood.
Ma'am, Dr. Nalini, can you prescribe contraceptive pills to her? Can you prescribe any contraception?
Yes, ma'am.
The answer is no.
No.
You cannot.
She's a minor. So
because she is a minor and as per POXO Act, you cannot advise oral contraceptive. You cannot advise any contraception because she's not supposed to be in a sexual activity. That is against the law.
Okay.
But for bleeding disorder, something.
But for bleeding, you can write.
Right.
But you know, she has bleeding, and so you can write the same medicine for bleeding, but you cannot write it for contraception.
Okay.
Is that clear?
Yes, ma'am.
So now, what are you doing to protect yourself medico-legally?
Yeah, we have informed the police, POXO Act. Then we will be getting the consent from the guardian, and we put it clearly that since she has come in a state of incomplete abortion, we need to evacuate. That's our duty. So after that, we put them, since all investigations show, and since she could be bleeding disorder, so we are prescribing this medications on the ground of bleeding disorder.
Yes. And one more thing that you need to do is you need to hand over the products of conception to the police. So you need
No
to
need
inform
for sending
and
it
you,
to HPE, histopathological, no need, or we have to hand over to
you
police.
have to hand over to the police. They will do what they like with it.
But we have to get the receipt from the police that we have
Yes.
handed it over.
Yes. So for yourself, you have to inform the police. You have to collect the products of conception. You have to hand that to the police, and you have to take an acknowledgement for everything. For the police report, for the products of conception, you have to take a receipt. So that is how you are protected medico-legally. So should I go to the next case?
Yes, yes.
Yes, ma'am.
So this is another case. This is a 15-year-old who's brought by her brothers for weakness. She can barely walk and she's carried into the OPD. She has been bleeding for 3 months. First period was an year back and she was amenorrheic for 6 months. Then she started bleeding. Being without a mother, the mother died when the girl was very young and the cause is not known. She did not tell anyone that she is bleeding. And she was brought when she couldn't perform the cooking and etc., the daily activities in the home. So what is relevant history here? What extra do you want to know from this girl? Her BMI is only 17.
Very much undernourished.
Yes.
Now she is anemic because fatigue, anemic. Now she's been bleeding for 3 months, so definitely her anemia profile we have to look into. But she was amenorrheic for 6 months. So
She
what
might
could
have
She just
galactoria.
had one period. Then she didn't have a period again. Then when she started, she just went on. It didn't stop at all. Okay, she has a BMI of 17. When we did her hemoglobin, it was less than 3 gram%. And she had a sickle cell carrier status. Now, what are the investigations you want to do on her? What is the clinical assessment that you're going to do? Jyotsna ma'am, are you there?
Yes, 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 I'm there. Yes.
Yeah, ma'am. So if you could just hear now in this situation, what are the investigations you want to do on her?
Okay, so your patient is having a sickle cell trait also. So this becomes, I think, more complex, this kind of situation, because I think she is very nutritionally deprived. She's anemic, and this child will be at a risk for developing, crisis also. In this kind of situation, normally sickle cell traits do well. But if they are bleeding and they become severely anemic,
She
then
has a hemoglobin of less than 3. Okay.
Oh my God.
So
Okay.
now what are you going to do with her?
Admit her, ma'am.
Yes, of course, she is a critical girl, which we have discussed in our talk just before. So she needs to be admitted. She needs to be oxygenated. She needs to be, given the blood and the blood products. We have to.
Wait, ma'am, wait. Are you going to give her any hormonal treatment? Are you going to test her? What investigations are you going to do?
Yeah, so
Other
we
than
have
those
to.
for anemia. Other than those for anemia, what are you going to do?
Yes, so coagulation, we have to do her coagulation profile also.
Okay.
We have to see, whether, because sickle red cells, they can modulate the clotting factors, clotting mechanism also. So that is
Any
that is
hormones
also.
that you want tested?
Yes. So
Molecular And thyroid.
Prolactin and
Thyroid.
thyroid. Very important. Because when she has a BMI of 17, we think, that we don't need to do the. But yes, then.
And then I think we should start the hormonal treatment for her to stop the bleeding. And
She
of
had
course,
a TSH of more than 150.
yes, so she needs to be started on the. I think we will need to do the complete hormonal evaluation. So along with the T3, T4, and also the anti-TPO antibodies, we have to see that. And then we will, of course, start the eltroxin treatment for her. So we start at around 50 microgram. We don't start at a higher dose, but in a stepwise way, it will be increased gradually. So we normally will start at 50 microgram, and along with that, we will do the other treatment, supportive care, and the blood transfusion. Because this hypoxia
around 28 kilograms. Her
Pardon?
weight was about 28 kilograms. 28. And the dose of thyroxin is 1 milligram per kg body.
Yes. So we will need to give a lower dose only.
We need to
Not
give her
even
a lower
50.
dose here.
We will need to give her
So
maybe
we
start
will
with
give her thyroxin. Now you are trying to correct her thyroid, but are you also going to add some hormones, estrogen or progesterone, to her treatment?
Yes, we should add. If she is bleeding actively, we should add. If she is not bleeding,
what will you say?
IV estrogen should be given, madam. Like Primarin, madam.
You want to give Primarin? Or you want to do an estrogen progesterone test and decide? Or you just want to start with estrogen or progesterone?
First, I will start with estrogen, madam. IV estrogen.
Then, sickling, sickle cell anemia, I think
hormonally
is probably estrogen may be a contraindication because of, again, the thrombotic complications. So again, yes, so I think we should be starting with the progesterone here rather than giving estrogen.
Okay, so now you started her on progesterone. Das sir, what do you think should be the dose and how long are you going to give that treatment?
It should be at least for 6 months.
Okay, and what dose are you going to give her? Is it going to be cyclic?
Medroxyprogesterone, medroxyprogesterone 40 mg BD starting dose.
40 mg BD, 28 patient.
I think we can give 20 milligram. We can start with 10 to 20 milligram BD. And then, yes, we can, once the bleeding is controlled, we can
see the
taper it to
response.
OD dose and continue till her hemoglobin is, built up. Or maybe we can continue.
Are you going to give a break or are you going to just continue with the medicine?
No, so we would not like to give her a break immediately. We would like her to become stable, hemodynamically stable. Her thyroid also, we give some time for the medication to start acting and build up her hemoglobin in the meantime. And we could give her a break after a month or maybe, because carrying on progesterone without a breakthrough bleeding is very difficult. Because when we give the estrogen progesterone, we can give longer 3 months. But here she may start having breakthrough. So we will need to, probably in a month or so, we may need to give her a withdrawal.
So we gave her 4 bottles of packed cells.
Yes.
Okay. And then she gradually recovered with her thyroid and all. And she was under follow-up for the next 5 years and she was okay. Okay. So long-term consequences, probably it was that thyroid which actually triggered the whole problem. Once that thyroid was corrected, she gradually recovered with that blood and everything. Now, because she's a sickle cell carrier, can you give her iron? That is my question to all my panelists. Can you give her iron?
We have to see her serum ferritin level first.
Yes. So her ferritin level was again almost undetectable, less than 2 something. So are you going to
We
give
can,
her iron or not?
we can give her iron.
Cell, we don't give them.
Ma'am, that is what, if she has an SS, which is the sickle cell disease, you do not give iron. But if she has a sickle cell trait and her anemia is not because of sickle cell, it is because she has blood. So it is an iron deprivation, and in this case, you can give iron till ferritin levels are normal. So this has to be remembered because there are certain areas which have endemic SS or AS. So now this is a third case. We are going to really go fast. A 60.
Sorry to interfere, madam. The previous case, maybe this is thyroid, everything, but she is a 15-year-old girl. Nobody to look at her at home, and only brothers have brought her. So no female ladies at
No
home.
female in the house. There's no female in the house.
So
she had 2 brothers and a father who was a policeman. So he was almost never available.
Yes, and a small child, maybe abused, and she was amenorrheic.
She was not abused, ma'am.
No, but we can, but we should take the history because she doesn't know and she is amenorrheic for quite some time. So we could think in that term also. So it was my suggestion, that's all. Okay, please, we'll go on to the next case.
So there's a 16-year-old who's brought by her mother for prolonged bleeding in menstruation. It does not stop without taking medicine. She is 5 feet 8 inches, BMI is 41, and she is preparing for 10th board exam. As per her mother, due to studies, she is up till late night 3 or 4 a.m. and gets up around noon when there is no school. Mother says she eats nothing. As she can nibble on potato chips while she studies, mother gives her that. So she has 3 or 4 packs of family size potato chips, and that is all she has. The mother is smart with a BMI of 22 and very healthy. So what is striking about this case? Let us not talk of routine. What is striking about this case?
Is suffering from
very much obese.
BMI is high.
Yes, she is obese. BMI is high. Dr. Das?
She is suffering
And her
from
lifestyle is very bad. She sleeps late night, gets up very late. So lifestyle and her eating habit is also very bad.
she is eating very less, but her BMI is 41. The striking factor is towards the PCOS, I think.
Sir, she's not eating less. 4 packets of family size potato chips.
4 packets, okay.
Right? She's not eating healthy, but she is eating. Her mother says she's not eating.
Mother needs counseling.
So what is striking and what investigations are you going to do? You're going to investigate for PCOS, right? You have diagnosed PCOS. How are you going to manage this case?
Lifestyle modification.
Improve her lifestyle. She needs the anti-obesity medication. We cannot manage her with the lifestyle measures alone. This girl will need, at 41 BMI, she will definitely need the drugs, or even she may even need the bariatric surgery, because otherwise I don't think she can be managed with lifestyle. Of course, that they have to be instituted, but it will be difficult to control.
Means how will you actually institute lifestyle modifications? Because even if you have bariatric surgery, you still need lifestyle modifications, right?
Yes.
So how are you going to do that?
This girl will need, she needs, basically her body needs modulation. This sleeping late and getting up at noon, this is a very important risk factor for the PCOS and for gaining weight. So probably she needs the therapy with melatonin also, so that she can develop her the cycles.
I'm asking a very simple question, and we are all experts here. This kind of mother and this kind of daughter.
So mother is
are you
also,
even going to institute lifestyle changes? Who's going to listen to you?
Yeah. No, nobody will.
बेटी तो कुछ खाती नहीं. She doesn't eat anything. My
So
girl
there is a
eats
denial.
nothing.
There is a denial from the
He
mother.
has to send to a psychiatric counseling.
Yes. So, and who needs the counseling? Is it the girl or the mother or both?
Both of them.
Both will need. Both will need. Definitely both need.
Both will need. So you will have to manage the obesity. You will have to manage the psychiatric component. And then you have to manage her long-term and short-term. Because if you make such a person lose weight, after a certain time, they start putting it on back, whatever procedure they do.
Yes, the mother thinks that she is not taking anything, so she is feeding her with all these unwanted food items, junk food. So that should be stopped. Proper eating habit should be instilled for her. That and all psychiatrist counseling will do all these things. And in addition, then exercise, everything should be done.
Okay. Pooja, you want to add something here?
No, ma'am. No.
Dr. Nalini, you want to add something?
No, ma'am.
Das sir?
No.
So we all agree on this, that you want her to go to a psychiatrist, right?
Yes.
Yes.
Now this is another case. She's an 18-year-old who comes with heavy menstruation since menarche. She does not pass clots but has gushes of bleeding and has to change pads every hour, which are fully soaked. Bleeding stops spontaneously in 3 to 5 days, but she is very pale. Okay. You can see bruises on her arms. She has no history of injury and her BMI is 22. So what is striking in this case?
The bruising over her arm. She may be having some bleeding disorder. That's why she's bleeding.
This looks like a case with bleeding disorder.
Yes.
So how are you going to manage this? You want to give mefenamic acid, tranexamic acid, or you want to investigate?
Investigate and find
First
out.
of all, I would like to investigate what kind of bleeding disorder does she having, and accordingly, I would like to treat, like whether she's having thrombocytopenia, any kind of any factor deficiency, or the specific investigation regarding her case. And according to her diagnosis, we would like to manage the case.
Okay. So
with
do
the
you
help of
think hemostatic
hematologist.
agents have a role? Because definitely there's nothing hormonal. Cycles are on time, bleeding stops on time. Only thing is bleeding is extremely heavy and there are no clots. Right. So
Antifibrinolytic would be the drug which we are looking for here.
Yes.
So tranexamic acid is safe. Mefenamic acid we would not like to give because it is antiplatelet and we don't know about, definitely that will not be a good choice. But we should give her on the first 3 days when she's having heavy bleeding, the tranexamic acid. And of course, here we need to start her on the treatment for the whatever is the bleeding disorder. So that has to be taken care of. So desmopressin may be added for this case if she is having von Willebrand disease, which is, desmopressin is the drug of choice there.
Do you want to loop in another specialist? You want to consult
Hematologist
should be there.
It should be hematologist. She should definitely be referred to a hematologist because that is the commonest. And plus, even ITP is a very common, diagnosis at this age. They may first time present. The girls with ITP may present. So I have seen many cases and even cases of leukemia who have come to me with, in this kind of situation, which has been described. So it could be anything, but definitely she needs the hematological evaluation.
Okay. Dr. Nalini, you want to add something to this?
Yeah. No, ma'am.
As she is very pale, I would like to do a CBC, and if she is very anemic, so I would like to give her blood or blood products according to her condition, as it is asked in question 4.
Yes. Would you like to give her iron?
Depends
Would you
upon
like to give her iron?
Here mainly we put them on antifibrinolytic agents, and then will be investigating. Then the iron is content is good and ferritin level is normal, no need for iron.
Okay.
But she is pale. She is very pale. That shows she is anemic, and in such cases we might add.
Okay.
If she is not having microcytic hypochromic anemia, I would not give her iron. Rather, I would give her blood therapy.
She has lost so much blood.
It is not a microcytic hypochromic anemia. It is because of hemorrhage. Right. So you would give her blood if she is less than 7. If she is more than 7, you're trying to give up iron to boost up, right?
Right.
Because this bleeding is because she is bleeding heavily.
Yes.
Right.
Yes.
So now we come to the next case. It's a 19-year-old. She comes for consultation. She complains of irregular bleeding for the past 1 year. She says she has to take pills to stop bleeding and starts bleeding again whenever she stops tablets. She had gone to a local doctor and year back, sorry for the spelling mistake, and year back for acne and had been prescribed some medicine. She never went again, but she continued medicine as she understood it. She is mildly pale, but she's very, very anxious. So what is this actually pulling your attention to? What pills is she taking?
Contraceptive. OC pills.
OC pills. And she is taking it? She
Yeah,
gets a low
irregularly.
acne, she
Irregularly,
takes the pill. Then that acne subsides, she stops taking the pill.
Yes.
So what has happened here is what is the relevant history here? What is the relevant history?
And irregular medicine.
Intake of tablets.
Yes.
What investigations do you want to do here?
So we would be looking at a case of PCOS at risk with acne and with irregular bleeding. So that is the diagnosis which we should be considering over here. So we need to do the testosterone levels for this girl. And of course, we should do the 75 gram OGTT, the lipid profile, because those are the, important things, and rule out any other cause of anovulation like the, TSH, prolactin, and even the 17 hydroxyprogesterone levels to rule out the late onset CAH. So I think that are the important investigations for her, which we have to do. Of course, ultrasound we may do, we may not do, as we had discussed previously, that it is not absolutely an indication to diagnose PCOS, but her picture is just like a PCOS case. So the other blood investigations we would like to do for her.
How are you immediately going to manage her? You've seen that she has that OCP pills. She has progesterone pills in her hand. And she's taking them off and on, off and on. Norethisterone tablets are there in her hand, and she's been taking them off and on. So how are you going to get her cycle in sync now?
Yes, since we have diagnosed PCOS, it could be anovulation, but she has taken progesterone, but the norethisterone also produces some estrogen. Because of that only, she has had a cessation of bleeding in between. So we should put her on. She's 19 years, so more than 8 years post menarche. So we can put her on OC pill.
Okay, what do you do in your practice? Dr. Nalini, if such a patient comes.
Ma'am, actually, I have one doubt, ma'am. She is complaining of irregular bleeding since 1 year. And for that same duration, she was taking medicines, ma'am, irregular use of medicine. Thinking that she is taking medicine for acne, ma'am. So it was given by a quack, ma'am. So maybe that for that reason she is getting irregular periods, ma'am. Before that, she is having regular periods, ma'am.
Great. So I totally agree with you.
Yes,
So we have to basically, because she has acne, we look for PCOS.
okay.
If she has bad acne, we look for PCOS. That irregular bleeding is definitely because of the tablet only.
Yes,
So that is why I'm asking you, how are you going to get her cycle in sync, which she has actually bushed?
I think she needs to be started on the OC pills. So basically, she has to be counseled, because this is the typical history with which any kind of patient comes. They start the hormones for them, but they don't tell that when you stop, you will have withdrawal bleeding. So when the patient comes, she will say, "Jab dawai khati hu, I am okay. The minute I stop, I have bleeding." So they think it is, yeah. So basically, I think it is very important to counsel them when we are giving hormones, that when you stop, the bleeding will come. Not to worry about it, but if you are giving it in a cyclic manner, you must tell them that after the withdrawal bleeding, you have to start again. So for this kind of girl, I would like to give her the 28-day pack, which will be very easy for her to follow. So with the mala and preparation, so and obviously acne will not respond to the progesterone. So she needs a OC pill, and we will give her 28-day packet. Explain to her that when you take the black colored pill, you will have period, but you start the next pill immediately after finishing the first packet. So I think that will regularize her cycle, take care of her acne problem, and also, for the till we are, investigating her further and putting her on the lifestyle measures, this could be, the treatment which we will have to give to her.
Das sir, would you like to add something here?
I will prescribe her for drospirenol and ethinyl estriol 20 mg for 3 months.
Okay.
I agree with Dr. Jyotsna, and this is the common situation when these girls stop bleeding, then they stop the tablets also. Then again, if they start bleeding, then they go to some other consultant. So proper counseling is needed, and we have to tell them that even if the bleeding is stopped, they have to continue the tablet, taper the tablet, then they have to continue it. So good counseling is definitely needed. So this is the common patients we encounter in our practice. So we should tell them properly, and we should make them understand the idea of giving OC pill continuously.
Yes. So basically, here the important thing is the counseling, that the patient should continue treatment. Don't stop in between. You went to one doctor 1 year back and never went again. So don't do that with me. When I'm calling you, come back in 3 months, please come back. Have that record with you. Because the history that she is telling you of a not so responsible patient. She has one prescription and she is done. So because of this irregularity and all, do you think there is going to be any long-term consequence?
So this kind of girl would be at a risk to have endometrial hyperplasia also. So definitely, if she is not taking her treatment properly, there is the risk of in her later, in fact, at a much earlier age, they can have hyperplasia, and also they can have, of course, other consequences of PCOS. We all know the metabolic this thing, endometrial cancer, all those are there, infertility. But I think we are worried that she should have a regular shedding of the endometrium is very important to prevent the hyperplasia and endometrial seal. And lifestyle are very, very important, and regular follow-up of this case is very important as far as the metabolic complications also.
Yes. So thank you for that, Dr. Jyotsna. Now we come to the last case. This is an 18-year-old who comes for acne and irregular scanty periods. BMI is 21. Just looking at her, she doesn't look very feminine. So what is the relevant history that you want to ask from her? What do you want to ask her?
Did she attend the menarche properly?
Secondary sexual characters.
Secondary sexual characters, yeah. Axillary and pubic hair, breast development.
Okay. So what do you want to examine in this patient? Secondary sexual characters.
Yes.
Okay. What investigations do you want to advise?
I think
First
here,
of all,
yeah,
ultrasonography to check for the size of the uterus ovaries,
actually
whether she's having
testosterone
uterus
is
and
very
ovaries or
important.
not.
Serum testosterone is high.
Yes.
Testosterone and even DHES, because if we are saying she's not looking very feminine, she has the masculine features. So we need to see whether there is any tumor, abnormal androgen secretion is going on. So, definitely here, not only testosterone, we would like to go in for the DHEAS also. Because the source of testosterone, the androgen could be the ovary or the adrenal gland. So both the things we have to see, that DHEAS also, and 17-hydroxyprogesterone also we would like to do. Along with the ultrasound.
She had come with her mother. So I asked her mother to show me her previous photographs, when she was 12, 14, 15. And she was looking normal, absolutely normal. And then this change has occurred. We've done her testing, and now there is a 16 cc solid mass in her left ovary.
Okay, so this looks like a
androgen secreting tumor could be.
Yes, androgen secreting tumor.
Yes.
So now what is your plan of action?
Yeah, so we will do the tumor markers for her. So
she is only 18. What tumor markers do you want to do?
Yes,
No,
so
I will
here
do laparoscopic removal, send it for
no,
biopsy.
we have to remove the mass staging. I think we will need to do a further radiological evaluation also. Tumor markers baseline, definitely we need to do all because a germ cell tumor is normally seen at this age, but germ cell tumors normally are not testosterone secreting. It is the granulosa cell tumors which are the testosterone secreting. So we have to do the inhibin B, I think, is the one which is the important tumor marker, plus the alpha fetoprotein and the
LDH.
The LDH, dysgerminoma. So those are the ones we will do. We will do MRI for her, and then we would like to do the because she's young, we will go in for the just the local removal of the mass, and go in for also the if we have got the facility, rather this kind of child should be opened only in the tertiary level where a frozen section would be available. And then if it is a malignant mass, we could go in for the other staging. Of course, we will not do any radical procedure, but we would like to maybe do the omentectomy or other things, the other part of the staging, and also maybe the biopsy from the other ovary if indicated. So these are the steps which we would like to do in this case.
Can I interfere?
Yes, ma'am.
If the patient is in a rural town like us and she is coming from a village, can't afford for all these tests, then what will be the thing we should, because we are facing with these situations. So what we will do will, practically what we are doing here, I'm telling, we remove it laparoscopically, then send it for biopsy. Then depending upon that, we'll decide, referring them to tertiary center. So any objection and any suggestions?
I think, ma'am, whatever we do, the counseling has to be proper.
Yes.
We should be able to do the best that
thing.
we can.
Yeah.
We need to explain it. We need to give the patient an option to go to a higher center. Yes, we should not take it for granted that the patient cannot go. We should explain that, these are the options available. And even if she's at a tertiary center, it should always be counseled that you might have to be opened again. This surgery may not be the final surgery and you may need to be opened again. So these are the basic points in the counseling and the informed consent that have to be taken care of in this case. And looking at past photographs, looking at the patient properly, when the change actually started appearing, and getting relevant testing, I think, is important. We should try to arrive at a proper diagnosis as far as possible. As far as possible.
Yeah, agreed.
So now we come to the take-home messages, and I would request all my guests and panelists to give one take-home message before we end the session. Pooja, I can see you first on my screen, so would you go ahead and start?
Sorry, ma'am.
One take-home message from today's program.
One take-home message that we should not take and in this fast life era and fast lifestyle era, we should not ignore their mental status and their sexuality, so that we would come to know in detail what the patient is going through, their mindset and everything. So that is one message from me.
Okay. Dr. Nalini?
Ma'am, yeah, history taking is very important, ma'am.
Yes.
But we should elaborately take history.
So as Dr. Jyoti Bhaskar had explained, that there are many kinds of history and you need to take all relevant history. Yes. Das, sir?
We should not forget to refer to a hematologist whenever it should be.
Okay. Okay. Chandra, ma'am?
Yeah, proper evaluation is essential before coming to a conclusion and diagnosis. Then treatment depends upon that.
Thank you, ma'am. Jyotsna, ma'am, you have the final word. And thank you for being with us so long.
It was my pleasure, ma'am. There was no other commitment at the moment, so I was able to participate. So from my side, I would say that evaluation is very important. The common causes we know are the HPO immaturity and bleeding disorders. Besides that, in India, we should always keep in mind about tuberculosis, because endometritis is a very common, again, cause in adolescents, to have heavy menstrual bleeding, and also amenorrhea. So I always rule out tuberculosis in my patients with good history, and even if need to do the AFB in the menstrual blood and the gene expert. And then of course the other message from, and the thyroid, which cases you showed, definitely very important again. The other important message, don't be shy to start the hormonal therapy in the girls who are having heavy menstrual bleeding. So be confident about that. If they need it, you need to give it. We can't allow them to become anemic and have a poor quality of life at that young age, when they are the most productive and they are studying and they have so much to do for their family, their country, and they are the building blocks. So we have to support them in a positive way. And short term, the hormonal therapy is not going to harm them if they are bleeding. So be confident to start it and do the proper counseling about it.
Thank you, ma'am. Thank you so much. So my take home is, please listen to what all our experts have said and practice it in your practice, because a proper diagnosis, a proper investigation, not everything for everyone, but as per the history, and adequate treatment and protecting yourself medico-legally. Everything goes a long way. When you are operating, take a proper consent and do only that much for which you have taken consent. You cannot do more or less than the consent that you have received, even if you have to open the patient again. So with this, I would like to really thank all of you, Dr. Jyotsna, Dr. Das, Chandra, ma'am, Dr. Pooja, Dr. Nalini. I'm really glad that you are here and you've made the program worthwhile. And thank you so much, ma'am. And thank you, Corona Remedies, for being our academic partners and helping us.
Thank you, ma'am.
Thank you,
ma'am. Thank you.
And you may end the session. Thank you so much.
Thank you. Thank you.
Thank you.
And wish you all the best again.
Thank you so much, ma'am. Thank you.